Hi, everybody. We are group number one, and we are actually going to be talking about cultural assessment with Peer Health Exchange. So my name is Jeff.
My name is Sam.
And my name's Vanessa.
This is actually something dear to my heart, as I actually am part of Peer Health Exchange. So let's get started here. So we're going to go over the the organization first. So Peer Health Exchange was founded by college students out in Colombia, and we realized there was a need for health education in classrooms. And so our current CEO was actually one of those founding fathers, or founding persons rather, and he founded the organization first called Community Health Educators. And this was in Colombia with 11 college students in 1999, finding out there's a need for health education in classrooms. And since then, we've actually grown to become Peer Health Exchange as a national organization. And actually our national organization moved from New York over to the Bay Area. And PHE's mission is actually to give young people equitable access to knowledge, skills, and resources that support their physical and mental health, with the core value of health being the central components of this. And we are actually here in Los Angeles with 4 staff persons. We actually just hired a the fifth person. That's not in this picture, but also our executive director is not in this picture. So we have an executive director. Her name is Dawn Best, a development manager, Megan Hayward, depicted on the right. I am the Los Angeles program director, and Cynthia Diaz is our program manager who actually manages the college sites. We actually just hired in a second program manager who will be specifically managing 2 other college sites. So like I said, Peer Health Exchange is a national organization with 5 different satellite locations. The national organization is located in San Francisco. But the other 5 locations are the Bay Area, so centered in San Francisco as well, but their sprawl is in East Bay and South Bay as well. Los Angeles, which is the location here, Boston, New York, which is the original site like I mentioned earlier, and Chicago. So the program model, so the one thing about Peer Health Exchange is that the organization is the program. So city sites are required to set up college chapters across the United States. And it's specifically here in Los Angeles, there's 4 college sites. So USC, Occidental College, Cal State Dominguez Hills, and Cal State Northridge. And those college sites are college students. So in the spirit of led by young people, for young people, and we'll talk about that in the next slide. Those college students are led by 2 co-coordinators and 11 leadership council members who recruit and train volunteers to be in the classroom. So like I said earlier, the program model is really centered on for young people, by young people. So this is really the crux of Peer Health Exchange, being that it's a near-to-peer program and really utilizing the near-peer relationship in the classroom. So in the classroom, meaning in high schools. And so college chapters then go and partner with high schools. And so the staff actually identify those high schools, and they go into the high schools in their areas. For instance, at Cal State Northridge, they're partnered with high schools in the San Fernando Valley, Occidental being in the East Los Angeles area, USC in the Dominguez Hills being the South Los Angeles area. And so they actually go in and teach a health education curriculum and take over as the educators of the classroom. So the health education program is a 13-week knowledge and skills-based program. And so it's centered on 4 primary skills, which is accessing resources, decision-making, self-reflection, and communication and advocacy. And so those are crucial because this is what makes us, or makes Peer Health Exchange different from any other organization, is because the crux of the program is on skills building. And then the health content is actually interwoven into these units. So those health content components are comprised of sexual health, substance abuse, and mental health. So a little bit about the demographic information. Just for privacy purposes, I actually did not know which high schools are which. but I know it's a little bit hard to see in this slide, but if you see those two arrows, there is an emphasis on Black and African American students in high schools, which are comprised of overall 5.56% of the total student population that we're serving, and then a staggering 88.41% that identify as Hispanic or Latinx. And so those are the two main populations, ethnic, racial demographics that we serve. There currently is no data supporting the LGBTQ components, as this is not included in a lot of self-reports in terms of our high schools, as it is a charter school system. So a lot of the schools that that Pure Health Exchange uses as charter schools, and so that component is actually omitted in terms of sexual orientation. But it's important to note anecdotally that that program managers have noted an increase in students that identify as LGBTQ, and so that's the third component of focus for Pure Health Exchange in terms of service. So like I said, you know, the students are mostly comprised of Latinx, Hispanic, African American, and LGBTQ students. And so in order for the organization to be able to best serve those populations, volunteer demographics need to be reflected as well. And so these are the current colleges in terms of volunteer demographics. And the yellow highlighted denotes that we are lacking in those areas. For instance, at Cal State Northridge, we only added 7.27% group of volunteers identifies as such. Occidental being 2% and 0% actually at University of Southern California. If you noted earlier that Dominguez Hills was included in this, Dominguez Hills is a new partner actually. So the Dominguez Hills partnership actually was just established last month. And so there is no data to be set here, as they are going to be a relatively, actually a completely new site in 1718. So a couple of things to know in terms of impact for Pure Health Exchange. They've overall nationally, they've served about 115,000 young people, 150 high schools nationwide, 8,500 college students, and grown from 1 city to 5. Previously, Pure Health Exchange actually was partnered to 6, but due to funding sources, the DC site was actually cut. And Pure Health Exchange has grown from 2 colleges, Columbia and Bernard, to now over 20 college chapters and growing. So make that an additional one. So actually that's a 21 college chapters overall. So what Pure Health Exchange does in terms of testing for efficacy is that they do pre and post testing. And a lot of data is posed from the last 5-year strategic plan, as Pure Health Exchange has moved into the new strategic plan. So there is no data to be set yet for the last year. But from 2014-2015, 70% of PHE high school students said that they learned already something of Pure Health Exchange that they intend to use. And 91% of high school students said that they would use something they learned in Pure Health Exchange. The proof is in the pudding here. The most important thing to note is that compared to other high schools that have not received Pure Health Exchange, there has been an increase in the use of behaviors that reduce substance use, specifically also the intention towards condom use and barriers for specifically actually for teen pregnancy. And so that was an overview of Pure Health Exchange. But going into our cultural assessment frameworks, we did as a group interviews and observations. And so this is a kind of a overview of what we use for the checklist. So we actually use a checklist, an observation checklist specifically, and an interview guide. So we're going to look at this observation checklist first, because this is important to know as we're looking at our results. And so the observation checklist was divided into the 5 main sections of our cultural assessment framework. And so 7 questions were asked for the cultural, ethnic, specific demographic characteristics. So that would mean that it was scored on a 5-point Likert scale. So the lowest score in this section would be a 7, and the highest score will be a 35. And so for the cultural ethnic group, epidemiological and environmental influences, there was only 2 questions that were assessed. So the lowest score will be a 2, and the highest score will be a 10. And then for the general and specific specific healthcare beliefs and practices. There are about 4 questions, so the lowest score would be a 4, and the highest score would be a 20. And then Western Healthcare Organization and Service Deliverable Variables, there were 4 questions there, with 4 being the lowest score and 20 being the highest. And so later on, as Vanessa will explain, the way we calculated the scores for these were the 2 observations. So there were 2 observations that were scored by two different folks in our team, and then they averaged the 2 scores for each section. And so we'll know in terms of the results from there. So the interview guide was more qualitative. So we understood that as a group that we would actually find a lot of lapses in our observations. And so we were meaningful about what we want to learn in these sections and want to probe a little bit deeper. We divided the interview guides based on our interests. As you can see, like those sections, like we have our names attached to them. And those were actually the guiding questions that we use in our interviews. And those interviews actually were specifically with myself. As you can see in my pretty picture, I'm the Los Angeles program director. I actually oversee all of program here in Los Angeles, and that lasted about an hour. And then with Cynthia Diaz as well, who's a program manager. As far as your observations are concerned, we actually we recorded actually an LGBTQ workshop, and we were so lucky and fortunate to be able to see a labbing specific workshop. So meaning that this workshop was not a standardized workshop. This was actually a pilot that they were that Peer Health Exchange was doing to see if components that they're using for LGBTQ was up to speed. And we'll actually just share you a little bit of a snippet for that right now.
Like, is it rape if someone says they're putting on a condom and then they take it off? Yeah. I looked that out because there's been a little bit of time, but
I heard about that too.
yeah, actually, I heard about that. And there's something in the law that if you have HSCI and then you have committed knowingly, right?
There used to be a law. They actually just took that out.
Yeah. Oh.
Yeah.
Cool. Then yes, that is definitely a part of.
Yeah, I would definitely say that's not consent. Our agreement was this, and that was not a part of it.
So now, including our everything that's for us and our bodies, by defining what health means to us, because everybody has a different definition of health. What's the point for you all to learn?
So this was just a snippet of the workshop. This was actually at Vaughn International Studies Academy in Silmar, California. The reason why it was done with traditional volunteers, meaning the volunteers would go in and teach, was because we wanted to make sure that the components that we were testing out were robust. I also omitted students because there was no waivers that were signed for their release, and so we could not. We omitted pictures of of the students, and so there were actually only 8 students from that high school that participated in this labbing exercise. So it lasted about an hour. The second observation that was done was actually a management meeting, specifically actually the program team meeting. So this was comprised of the program director who led the meeting alongside the program manager, which is Cynthia Diaz, and 3 other interns that were interning for the summer. So 2 from CSUN and 1 from Dominguez Hills, all undergrad students. So now I'm going to switch it over to our wonderful team member, Vanessa, for Cultural Assessment Framework results.
So what we noticed is that in reference to the cultural and ethnic group, specifically epidemiological and environmental influences, they had the highest score rate of 90%. What must be noted is that there were 2 questions. The first one being students feel comfortable in the spaces where the program is delivered. And the second being social and environmental health hazards specific to LGBTQ, Black and Latinx populations. The lowest score rate for cultural ethnic specific demographic characteristics had 7 questions. it included how informed is the organization with the primary language of the cultural or ethnic group, which is Spanish. The organization, does it address English language learners in the program design? The organization is highly informed about the Black and Latinx as it relates to the program planning and curriculum. The volunteers reflect the gender and demographics of the students served. Diversity is represented from the recruitment and hiring of volunteers and staff. Materials are appropriate in terms of complexity for health literacy level group of focus. And are there services that are sensitive to religious backgrounds? The highlights that we noted were that PHE is focused on bringing Spanish workbooks to English language learners. The main staff was mostly made of female and Latinx, and 60 to 70% of staff and volunteers will be Latinx and Black by 2023. So many Black and Latinx students do not apply for leadership roles for college chapters, but luckily PHE is currently assessing this outcome. When it comes to the synthesized results, we noticed that the cultural forces guide the group. They're very tailored to Latinx and Black communities. They incorporate identities and role plays. Whole intercultural program is revamped for the current year, and they have a heads-on approach where they help the students on a personal basis. They focus on gender and ethnic identities, and by that I mean LGBTQ students. They also have cross-cultural concepts that are implemented for Latinx and Blacks. They have no gender or socioeconomic language or religious bias. They also have volunteers that understand these biases. So basically trainings. The demographic information is studied from high school records, and the delivery of the program is through high school settings like the high school. What is it called? Sorry. Volunteers are relationship driven. In reference to the epidemiological and environmental factors, they focus on the health and socioeconomic disparities in the community. Only Title I schools are focused, and they identify hotspots. They relate to teen pregnancies, STD infections, drugs, and alcohol abuse. They focus on mental disability and suicidal tendencies. They focus also on morbidity and mortality data from 14 schools. They're mostly linked to Blacks and Latinx in Watts and Compton. They also work with a competence in ethno-sensitivity, and they also have a diverse advisory board. They have subcontractors that include a college graduate that comes from LA LGBTQ Center. They have experts in the teen pregnancy sector, and they also work with advocates for youth, which focus on LGBT, Latinx, and Black members. They also pilot health clinic outreach to 5 schools in a 5-mile radius. They have youth competent and friendly advocates, so the volunteers and staff. They cater to FQHC and CHC populations for Latinx teenagers. And now I'm going to be presenting you Sam.
Okay, thank you, Vanessa and Jeff. So you already know most of it, but now I'm going to focus on general and specific ethnic group characteristics, and this is regarding the ethnosensitivity. Now, as Jeff had said, that this is for the youth and by the youth, which is kind of sound very linkedness, but they are kind of nascent in creating cultural awareness. They're just kind of 2 years down the stream. All volunteers go through training for Latinx, African American, Blacks, and LGBTQ community. And there is also implicit and self-bias training throughout the year. So now we come to the general specific cultural characteristics, problem-solving skills, and these are the principles of education that they kind of embed on their population. They develop their listening and communication skills, which was told to me by Dias. Then they develop confidence in reporting sexual assaults, which you know that not many of people confident still of reporting that. They administer A to G requirements that focus on self and community. And then as you saw those, the videos, there are 3-minute videos on decision making and to control alcohol and substance abuse. So as far as general healthcare beliefs and practices are concerned, there is no one size fits all. In other words, we know that there are no specific models for just one problem. But mainly in general, we can say that there are cognitive and behavioral theories that are broadly applied. There is the health belief model that helps to remove barriers and helps in decision making. We can also apply the social cognitive theory in the health belief model in developing the self-efficacy and motivation of the participants. And workshops then are designed to remove barriers and develop self-efficacy and motivation in the use of condoms. So goals and objectives and delivery variables. Sensitivity to growing ethnic population, which is a must for them. They have a strategic plan for 5 years and 1 year objective markers. Participation, outreach, and volunteer retention were exceeded this year, which, give a clap to Jeff over here. Objectives, it's all his leadership that is going on. And objective for 2018 is to have 35 Latinx and 5% Black volunteers. Good job, Jeff. Goals and objectives, strengths and weaknesses. Well, thought out. There's a well thought out target group needs, and they're changing over to a relationship consistency model, and also I think lengthening a bit of the program. Same volunteer for 16-week program. That means they will have the same volunteer tutoring the participants, which bonds the volunteer and participants, creates trust. Sessions are interactive and not didactic, as you saw in the snippet of that video, which means that the participants feel they have created their own solutions and they have come forward with a solution. The weakness, of course, will be the commitment for the 16-week volunteer, because that is always a challenge to have somebody teaching for 16 continuous weeks. Now, enabling factors, there are principles of reinforcement. Access to healthcare education in schools is an enabling factor, of course. Reinforcing factor are peer-to-peer teaching, peer volunteers who motivate participants, and predisposing schools, as we saw that the schools are located in identified hotspot areas. They have high areas of teen pregnancies, STI infections, poor mental health, and high substance abuse. So what is the conclusion we take from all this presentation? That PHE is in the beginning stages of assessing for cultural competence. It has been only 2 years down the stream, but they're doing a good job. It's an upward curve. The need to incorporate more structured ways of evaluating. Practically, there is no evaluation structure in place right now. Segments scored low in observation assessment may be a factor of lack of structures and need to be worked out from the national level. So this is something that Jeff is kind of tasked to do. And PHE's achievement and goals is encouraging as they continue to become culturally competent. We attended one of the meetings and we saw them, they had exceeded the goals. So now in conclusion, we have to give the references. Here are our references.
And thanks, everybody.
That's Vanessa, by the way. Dancing.
Thank you, everybody.
Thank you.
Bye.